Next on call, surgery to repair a hole in a heart.
Defect between the two upper chambers.
And healthy eating for your vascular system.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
There's the valve.
All of them together.
And which was healthier, the yogurt and the bagel?
All right, I'm going to start by measuring the size of it.
You could also add grilled chicken to this recipe.
Blow hard! Blow, blow, blow! Keep pushing.
And try to push your head.
Pull red handle to open bag.
Hello and welcome to On Call. I'm Tammy Watson. You may be familiar with the idea of heart health. In fact, February is American Heart Month, and an idea that should go hand in glove with heart health is vascular system health. After all, the arteries and veins and capillaries that make up our vascular system route life-sustaining blood throughout our bodies, and vascular disease is often mentioned in the same breath as heart disease. So tonight we're going to talk about vascular disease, and here to answer the question, what's in those pipes? In the studio, ready to answer your questions on this topic, are Dr. Michael Bacharach and our on-call medical editor, Dr. Rick Holm. You can call in with your questions about our topic right now. Our phone number is 1-888-DOCTOR-ON-CALL. Again, that's 1-888-376-6225. Helping answer the phones tonight are volunteers from the South Dakota State University Pre-Professional Science Club. Dr. Holm, before you introduce our guest, tell me, what kinds of vascular disease are most common in your practice? What do you see a lot of?
Well, if you think about it, vascular disease is really that major aging process that happens when you get older. And eventually, it's when you get into your hundreds, your vascular system is your Achilles heel, you know, it's the thing that... And what happens? People have heart attacks, people have strokes, people's kidneys quit, people have blood vessel problems to their feet. It's the vessels that really keep us functioning, and when they fail us or when they block off, we can have major, major trouble. So that's why we need people like Mike Bacharach to help us out. And we've got the guy here today. I am very pleased to introduce to you our guest for this evening, Dr. Mike Bacharach. Michael Bacharach is a cardiologist internist, or a cardiology internist, or a vascular internist, so you might want to say. Specialist at North Central Heart Institute in Sioux Falls. Welcome, Mike.
Thanks, Rick. It's really nice to be here.
So, are you a cardiologist, a vascular specialist, what is your, you have a variety of titles. What are you?
Well, my initial training was in internal medicine, and then I did a fellowship in cardiovascular disease, which would traditionally be called a cardiologist. And then I did additional subspecialty training in the area of vascular medicine. So,
and where did you do the vascular specialty training?
Well, I did part of it at the Mayo Clinic in Rochester, and then I did an additional year of training at the Cleveland Clinic. And
Cleveland Clinic has been renowned for this whole area, has it not? Or what is kidneys as well?
Well, Cleveland has a reputation as being one of the world's busiest heart centers in the past. It was really the place in which bypass surgery for hearts was, in fact, first developed. And they've been leaders in the area of heart and vascular disease, and they've been very innovative, and been was fortunate to have had an opportunity to spend some time there.
And you had an opportunity to come to Sioux Falls to the North Central Heart, and you did that because it's a good place.
It's a great place, and I have great partners. I have great surgical partners and great cardiology partners, and we really are a team. And I think that's what makes it such a unique place to work, and it's a fun place to be.
You're a hybrid, really, aren't you? You're half surgeon, half internist.
The term nowadays it's thrown around as an endovascular surgeon, and that's someone who fixes the blood vessels from the inside out as opposed from the outside in. Right. And so I think I fall into that category.
The endovascular inside surgeon. We're really happy to have you here.
Well, thanks.
We're ready for any kinds of calls. This is a very important topic, and you know, fixing the heart, fixing the carotids, fixing the so give us your calls. We'll be waiting for it right after this.
Your peripheral arteries and veins carry blood to and from your arm and leg muscles and the organs in and below your stomach area.
Technology keeps advancing, and a new robot is the showpiece in a new state-of-the-art medical facility at the Avera Heart Hospital in Sioux Falls. Dr. Tommy Reynolds, a cardiovascular and thoracic surgeon who practices at the Heart Hospital, explains.
This new lab is the Siemens Artis Zigo. It's a new robotic vascular lab that we have, and it's new quality, better imaging, and allows for less radiation for patients as well. With the way the camera's set up, this robotic vascular lab allows for imaging, really 360-degree imaging. You can go top to bottom instead of limitations by the table or the camera. And with the movements that it has, it can start at the head and go all the way to the feet without a lot of movement. And that's the robotic part that allows us to do that.
Dr. Michael Bacharach, a specialist in cardiology and vascular medicine, says that the positioning flexibility of the new robot, along with high-end visualization tools, make for a better experience for both patients and physicians.
Not only do you have the 360-degree rotational imaging that allows for three-dimensional, you also have a different types of imaging intensifier that represents, it's no longer what we used to call an II, it's an image intensifier that provides markedly improved imaging. So this really, again, is state-of-the-art current technology. So not only is the robotic arm new, but also all of the computer, all of the technology and methodologies that are used to create the imaging, and which allows for less contrast exposure, allows for better pictures, hopefully which then will translate into improved efficiencies, safer and faster treatments.
Most of us already know that what we eat plays a major role in our health, and when it comes to vascular health, there is a specific diet called the Anti-Inflammatory Diet that is recommended by the dietitians at the Avera Heart Hospital. We talked to one of them to learn more. Avera Heart Hospital dietitian Nikki Versteeg wants people to know about the anti-inflammatory diet.
The anti-inflammatory diet is a component of nutrition that helps to be able to lower inflammation in your body by consuming appropriate foods. When we're talking about inflammation within the body, we're talking about that related to arthritis, increasing your risk of cardiovascular disease, also increasing cancer risk. A lot of people find that they get symptom relief from some of their arthritis situations, which is very interesting and almost a nice side effect of what it's doing to lower your risk of heart disease.
Some of the foods that Versteeg says fit well into an anti-inflammatory diet include old-fashioned oatmeal, walnuts, apples, and red onions. And she says trips to the grocery store should include shopping for plenty of fresh fruits and vegetables, lean cuts of meat, and fish like salmon or herring.
Things to not include in your diet or to cut down on, and this is a big one, would be to limit your processed foods. A lot of times people think if they add in the healthier foods that's just fine, but they also need to remember to cut down on some of the other foods.
If you'd like to learn more about some of the foods recommended by Versteeg and find some easy recipes for healthy eating, you can go to the Avera Heart Hospital's Healthy Kitchen website. That web address is avera.org/heart-hospital/healthy-kitchen. Again, that web address is avera.org/heart-hospital/healthy-kitchen. Doctors, before we get into the details of vascular disease, let's talk about the role that a healthy lifestyle can have in warding off the need to come see you doctors about this problem in the first place.
So I would ask this question, Mike. What is more important, an exercise program or a proper diet program?
Well,
that's a loaded question.
Yeah, actually, I think they really are complementary, and one needs to do both. There's no question that exercise and regular aerobic exercise, you know, biking, swimming,
the huff and puff kind of things, not the weightlifters, right? But the huff and puff.
Those types of things are very important, and it has been shown in many studies that it prolongs life and it improves quality of life. So those are really that's a powerful combination. Most of the survival advantage is done because, or is achieved through decreased cardiovascular events, but that's not all of it. And if they've done surveys looking at people in different 10-year age groups, clearly the people who exercise regularly function at a much younger level than their actual age, and they stay much more functional. So I think the quality of life issue is really a critical one. Diet is important, and it's hard to exercise if you're carrying too much weight. You know, so I think you really have to do both.
But it's a harder issue to do. I mean, you know, the New England Journal recidivism rate, how much return of weight occurs on Weight Watchers and all these programs, the best programs of weight loss. After 1 year, 30% of the successes, which were only 30% in the first place, were able to keep it off. In other words, 10% of the original. 30% were able to lose weight. And of that group, 30% were able to keep it off a year, and of that group, 0% were able to keep it off 5 years. So that, I mean, you know, we all say that, and we all want that. But these people who are heavy seem to reset their osmostatin, even if they eat less. Their weight stat.
I think though that I think you're right, and certainly you can be well nourished and still fit. So I mean, you can still carry a little bit too much weight, and perhaps you don't fit into the exact genes that you would like to. But in fact, exercise is still very important.
Well, that's an important point. I mean, and the data says that those heavy people that are exercising live just as long as the thin people.
That's right.
That's it.
Is it too late if I'm heavy and I'm a smoker? Is it like I've already damaged my system enough that?
Ooh, you said the magic words.
Oh yeah, we're going to go off.
Well, if you look at the traditional cardiovascular risk factors for both heart disease and vascular disease, it includes hypertension. You know, your blood pressure is elevated, abnormal blood fat, people who have high cholesterol, diabetes, family history, and cigarettes. And if you were to look at all of them, cigarettes is worth 3 of the others. So if you were going to do one thing to improve your overall health status, even if you have disease already, if you want to prevent it from getting worse, smoking cessation is the most important thing you can do for yourself. Far more than what I can do with pills or with angioplasty or with any of those things. Really, cigarette smoking or cessation of cigarette use is really the critical issue.
Devastating on the body.
Can my family doctor help me with quitting smoking before I have to go see him?
I mean, it doesn't matter how long you've smoked. The horse is not out of the barn. There's always time to quit right now. And your family physician, your internist, your cardiologist, your cardiovascular, endoplastic, whatever you are, we'll all do what we can. And you know, Chantix helps, bupropion helps, the patches help, psychological things, hypnotism helps, anything and everything.
I don't want to dwell on this topic too long, but what's going on? Why is, physiologically inside the body, why is cigarette smoke so hard on the vascular system?
Well, you know, I think that first off, there are many different organic compounds contained in cigarette smoke. So it's not just nicotine, it's many of these organic compounds. You take it into your lungs. The lungs is really like a big sheet of blood. It absorbs them very efficiently. And if you think of the blood vessels, the vascular system as really being the pipes that go throughout the house, in fact, you basically now are coating the inside of the blood vessels with those organic compounds that are absorbed into the bloodstream. So basically, you're saturating the inside portion of the blood vessel with these various toxic substances that in fact then leads to irritation and the healing process, which then becomes abnormal and results in the development of plaque and then further narrowing, or in some cases, destructive elements of the blood vessels that cause them to dilate and form aneurysms. So lots of bad things, actually.
Okay. I mean, it's amazing. I've never heard it described as well. You know, the lung is just a sheet of blood.
Yeah,
it has an opportunity to interact with the oxygen or the air that we breathe and that sheet of blood picks it up. The carbon monoxide is part of that whole thing, the poison that's in burning. Of anything there's burning. If you're burning it in a sauna, like I did last night with a bunch of guys, we had a sauna, we were all debating, arguing the carbon monoxide, if there was smoke and so on and so forth. But the issue of burning anything will cause carbon monoxide poisoning, which basically steals oxygen from the from the sharing of oxygen throughout the body. So it just oxygen depraves our body.
Okay, so if my blood cell grabs onto carbon monoxide as opposed to oxygen,
it can't let go. It can't get the oxygen instead.
All right. Well, I'm wondering if now is a good time to, you touched upon some of this, how the cardiovascular system works. Just kind of some of those basic 101 biology things that...
Tell us, start from Harvey's original description that says it crosses through the lungs, and explain the circulation.
Well, we think of the heart as a Valentine, very much as just Valentine's Day a few days ago, and we think of it in that how we draw the heart. But in fact, what it is two separate pumps. There's the pump on the right side, which is called the right ventricle, and the left ventricle. And the right ventricle is the venous side, and that's kind of a low pressure side. That right ventricle doesn't have to work very hard. What it does is allows the blood flow to come back towards the heart, and it sends it to the lung, where it gets its oxygen. And of course, from grade school or high school on, we learn about the blue system and the red system. The blue system is the venous side. It's deoxygenated blood. It receives its oxygen at the lung, and then it drains back into the left side. The left side is the high pressure system, and it then forcibly pumps the blood to all the blood vessels. So it goes out.
All the blood vessels which supply every single cell of our body. Everybody. Every teeny little cell gets a supply.
Right. So it's a closed system, and I tell lots of my farm folks it's just like their hydraulic system on their tractor. It's a closed system. And the venous side is like the reservoir, and the left side is like the slave unit that actuates the pump or that lifts the bale or does whatever the work they're trying to do.
That's right. Okay. And the work is to push it out through the vascular system, which in and of itself is also a pump because it's elastic. And when the heart squeezes, it pushes it out to the tissues, and then the tissues are elastic and push it back to the heart, and the aortic valve closes, at which time it feeds the arteries of the heart itself, the coronary arteries.
Okay. Well, I have to quickly apologize to our viewers. We're having some problems with getting our phone calls in, but we're going to try to read your minds and ask the appropriate questions.
The phones are not, we're in trouble.
There's something going on. So back to, you mentioned the vascular system is elastic. So when it stops being able to be elastic, you have problems?
Blood pressure's, the top number goes higher and the bottom number remains low, and you end up with much higher pressures. How would you explain it?
Well, that's right. As the blood vessels become stiff, they can no longer relax, or they lose that elastic ability. With that, there's a certain amount of potential degeneration or destructive elements that occur in the blood vessels, and especially in the big blood vessel, and that's when people talk about aneurysms, for example, of the aorta. That would be a classic example of stiffening, loss of elasticity, and then what happens is the body tries to remodel that large blood vessel and because it's under pressure, it tends, in some patients, not everyone, it tends to dilate and get big. And then, of course, it can create all sorts of problems, including it can break. So when that happens, when it ruptures, it's a catastrophic event.
Yeah.
I love to say this to people though. We automatically presume that if there's a blockage in the artery, we're done. Everything downflow dies. And I love to say the fact that in 7 years, there's not one cell in our body that isn't replaced. We are an image of what we were 7 years ago. It's a changeover. We're constantly rebuilding. This is a changing.
Okay, this is like all the dead skin cells that we wash off.
Yeah,
in the shower,
but every other vessel, every other cell, the bones are replaced. Okay. Everything is replaced in 7 years. Okay, and what does it do? It replaces and it repairs. And when you don't have an artery that flow to an area, and there's parts of it that's calling for some help, then you make new vessels. That's So explain that.
Well, what you're describing is what we call collateral flow, and it's the ability of the body to accommodate for changes. And when those changes do occur, if you do develop narrowings, especially if they narrow gradually, we often accommodate them so that even if you develop a complete blockage, for example, in the blood vessel to your leg, doesn't necessarily mean that you're going to lose your leg. You may have some diminished functional ability, or you may have some discomfort with walking, but through walking and exercise, you can actually improve blood flow and recruit these natural bypasses to occur. And so that's why one of the reasons why exercise is one of the cornerstones of therapy for patients who have blockage, for example, in their legs. And again, your point about the regeneration potential, I think highlights the reason why you need to stop smoking now, even if you smoked for 20 years. It's why you need to change your diet. It's why you need to start an exercise program, even if you haven't done it for a long time. So
rehabilitation is what we should all be doing as we get older. The classic story of a frozen left arm from a person who had angina. Tell us the story of a person what used to happen before we really were able to intervene.
Well, you know, it's interesting, and I was at a conference a number of years ago, and one of the people that was talked about, and many of the viewers will know, is President Eisenhower. You know, he suffered numerous heart attacks, and in fact, the treatment was bed rest. And he went for prolonged periods of bed rest, and in fact, he lost a tremendous amount of functional capacity. Now, he didn't have a frozen arm, but in fact, that's how we did. We immobilized people, which was exactly the wrong thing to do, but we didn't know at the time. Yeah. And so we thought that rest and immobility would provide the reparative process, and in fact, it was really the opposite. And we should have got him into a cardiac rehab program or an exercise program, but didn't. But you know, that's how much it's changed over a number of decades now.
Bob Copeland, who is a famous cardiologist, trained at Harvard and then ended up in LaGrange, Georgia, and was my teacher at Emory when I was a student, was showed me a patient whose whole left arm was atrophied and frozen. And he said that was because of angina. It was heart disease. It hurt in the left arm, and she became afraid to move her arm, and the arm became less and less functional, and then she was pained her whole life in her arm, and even when the heart, went on to, and she didn't die from it, her left arm was frozen from it. They've got a name for it. It's a heart arm. It's a angina arm or something. But
it predates me a bit.
But the whole, yeah, it does. But the whole story is that of if you don't use it, you'll lose it.
Right.
Okay. Question for you, blood clots. What causes them, and when do they cause a stroke?
Well, blood clot's a generic term. So remember, and we described the blue system and the red system, the venous system and the arterial system. And you can have clots in either one, but they cause different things. Okay, so if the blood clot occurs in the venous side, which actually is probably more common, that's what we call a deep vein thrombosis. That can lead to a blood clot that goes to the lung, called a pulmonary embolus. And that's patients who've had surgery or been immobile for a time, transatlantic flights, long car rides, lots of different things, right, can predispose an individual to that. And so typically, if you get a blood clot in the vein in the leg, it will get swollen and painful. Now that's very different on the arterial side. If you have a blood clot that forms, certainly one of the most common things would be a clot that forms perhaps in the left side of the heart and then goes up due to atrial fibrillation or irregular heartbeat, and it'll cause a stroke. And that's why many patients are put on blood thinner who have atrial fibrillation or who have a tendency to form clots on the arterial side. Clots can, in fact, affect the legs, arms. They can go back into the heart itself. So you have to differentiate. Blood clot's really a very generic term.
Okay. It's both sides. And you have to realize also that something like 80% of all people will die of a clot. I mean, if you think about it, it's in the nursing home. Yeah. They're sitting there. What is a clot? A clot goes to the brain, a clot goes to the heart, a clot goes to the kidneys, a clot goes to the legs, all those vascular areas. And they clot off when they're just sitting there and they're not moving and they're losing ground because of Alzheimer's disease or earlier stroke or whatever it may be. And so you have to think that the death that eventually occurs to all of us, 80% of the time, some has said, now I don't know if that's perfect, Mike, but Some have said that it's due to a clot.
Okay.
And so I don't have a problem with anticoagulating people who are functional. You know, they really got their noodle and they're going and they want to be active. There's a new treatment besides warfarin, a new anticoagulant, and it's all the rage. I am being really conservative. I'm afraid of it. I don't think we know the data enough, and so I have not started it. I know that people are pushing. Well, I'm going to ask the expert.
Yeah, that's dabigatran, and that's it's a direct thrombin inhibitor. The pharmaceutical industry has worked for many years to try and develop a blood thinner that was effective, that didn't require the same kind of intense monitoring that someone who's on warfarin or Coumadin, which is the standard anticoagulation that we still use. Part of the variability in why patients have some patients have so much trouble with the anticoagulation with Coumadin is that it's influenced by what they eat, okay? Because it affects the mechanism by which it works is vitamin K, affects the liver production of these clotting factors. So that's the advantage of dabigatran, that it doesn't do that, and that in fact it's a direct inhibitor. Therefore, now that I think that the initial study, certainly in atrial fibrillation, show that it's as effective, and in a higher dose, it's actually more effective than Coumadin alone. Now, as with all new things, it's more expensive. It's considerably more expensive, and I think that's really the downside. I personally think it will ultimately replace traditional warfarin therapy, and we'll use it for patients who have clots, patients who have atrial fibrillation, that sort of patients with heart valves, but that's still to come. And clearly the cost issue is going to be
it's still twice as much, even if you're checking pro times regularly. I mean, it's
right now it's very expensive, given that warfarin is actually pennies a day.
Okay.
So.
All right. Well, we're going to move on to our next segment now. In our story coming up, we'll step away from the topic of vascular health and briefly consider heart surgery, a closely related topic. On-Call was given a terrific opportunity to videotape Dr. Bacharach as he and a team of specialists at the Avera Heart Hospital repaired a heart defect known as an ASD, atrial septal defect. Here's our report. With a focused and fine touch, heart surgeon Dr. Michael Bacharach uses a catheter and a monitor to repair a hole in a patient's heart that is causing a problematic murmur.
This is a middle-aged man who was found to have a heart murmur. It was discovered by an ultrasound of his heart called an echocardiogram that he had a defect between the two upper chambers and that blood was flowing from the left to the right side. So he was shunting blood away from the normal outflow track and going back into the venous side. It's important to know that not all heart murmurs require surgery, and that murmurs can be caused by various conditions. But for this patient, surgery was considered in his best interest. So the physicians will proceed with a procedure that uses a medical device to close the congenital hole in this patient's heart, an atrial septal defect, also called an ASD. This is called a transcatheter closure of an atrial septal defect. What you'll see today is a catheter placed up through the large vein from the leg up into the right side of the heart, into the right upper chamber or right atrium. What we'll then do is cross this defect. We're going to measure the size of the defect and then place a disc-like device that will essentially plug or close the hole and will bridge across the two chambers, or between the left atrium and the right atrium, and then will prevent that blood from flowing the wrong way. Working in the cath lab, that's the operating room where this procedure is taking place, gives the physicians the tools they need to operate on the heart in a minimally invasive way. Instead of cutting open a patient's chest, a small incision in the groin gives access to the vascular system and, via this, the heart. Doctors use X-rays and ultrasound imaging to locate exactly where to place the device that will seal the ASD hole. Typically the procedure will take anywhere from 30 minutes to an hour. They are intubated, meaning that they're under general anesthesia. They'll get extubated while they're still in the room. Generally they get then sent upstairs and will stay overnight. Usually later today they'll be up and around, they'll be able to eat, and typically will go home tomorrow, sometime early in the morning. So most patients do not require any type of prolonged recovery. It's a relatively straightforward procedure.
Thank you for joining us tonight. We're talking about vascular disease, and here in the studio, ready to answer your questions, are Dr. Michael Bacharach and On-Call Medical Editor, Dr. Rick Holm. Now, doctors, let's follow up a little bit about the segment that we just saw. That's not vascular so much as
the heart is the big pump of the whole system, and I call it part of the vessels, wouldn't you?
Well, it's clearly the main center of the circulatory system.
Yes.
Okay, so I just totally misspoke there. I apologize.
So let's talk about what a VSD and an ASD are. This was an ASD.
Yes. You know, this falls into the bailiwick of what we call structural heart disease. These are patients who have a defect, either a patent foraminal valley, which is a hole that we all have that normally closes at birth, but in some cases, 15 or 20% of patients doesn't close, and then is a potential for clots to go from the right side to the left side. And then the atrial septal defect, which is a fixed hole that the blood then goes from the higher pressure system, it goes backwards, it goes into and tends to overload the right side, the blue side. So those would be, those in the past required an open operation to repair, and in some cases, a very large defects still require surgical intervention. But these newer technologies now with transcatheter closures, you can go in with a disc and actually across that defect and repair them that way. The VSDs are, again, there's a congenital type of which is that you're born with, and then there are some that occur due to damage from the heart, people who've had heart attacks and so on. Those are very complicated, and that still requires generally requires open surgical intervention.
So the ASD is an atrial septal defect. I mean, it's a hole in the heart that's between the atria, the upper chambers that are low pressure. Right. And the ventricles, here's the pump, the right side, which is the blue side, and the red left ventricle is the real pressure point that really pushes it around. When there's a hole in that system, then it blows it over to the right side, doesn't it?
Yeah. And that's and those are more complicated. Now there are centers in the country who are doing VSDs with a transcatheter technique. Generally, they tend to be pediatric cardiologists who are doing a lot of congenital type of things, people who are born with various kinds of defects. And those defects generally are not isolated. You know, it's not just a ventricular septal defect, but usually is associated with some other things. So the atrial septal defects are much more common, and what's interesting about them is that they frequently go undetected. It's not uncommon to have an elderly patient come in and you listen and you hear a heart murmur that, suddenly, you do an ultrasound test, an echo test, and find out that in fact they have a defect that they were unaware of. So they're not, you can go through certainly young adulthood without any detrimental side effects or symptoms, and then it can be discovered later on in life.
Well, that patent foraminal valley, there's some argument that says, well, we repair those, is it really making a difference? I think you might have the data, but now let me just explain a patent foraminal valley.
You do a good job of this. So.
This is one of those things that makes a person believe in God, Here is this baby that's sitting in his mama's womb and is receiving circulation from her, from the placenta. So this baby doesn't need to have lungs. The lungs are sitting there collapsed, not working. No breathing needed. You're getting blood from mama. Okay? So the blood comes into the right side of the baby's heart, okay? And it passes over to the left side where the pump pumps the blood through the baby's circulation. Okay? So the right side is in quiet contentment, not doing anything until that moment when the head pops out and the baby goes, and the lungs expand, and the patent foraminal valley, which is a big hole shooting the blood from the right side into the left side, closes off, and now you've got circulation through the lungs and the way it is when you're an adult. Now, it just amazes me that whatever we have, that system can close off that hole. And sometimes it doesn't close off completely, and there's a little leak. When do you know to plug it? And it's when they have a first stroke. Is that what you're doing?
Yes. What this allows, this short circuit, as so to speak, that potential hole could allow in adulthood then a clot to go from the right side to the left, which normally would traverse, couldn't get through the lungs and could never get there. Right.
Be filtered by
That's
the
right,
lung.
and couldn't get there. So clearly the most devastating and concerning event is a stroke. Now what's happened is that there are young patients who have strokes that we can't explain, and we have names for all of that. We call that a cryptogenic stroke, meaning we don't know. It's not due to blockage in the carotid artery, it's not due to blockage in the blood vessel inside the brain, it's not due to a subarachnoid hemorrhage in the brain. It's something that we don't fully understand. So with new technology and better imaging, we've now identified that in some patients this patent foraminal valley is a potential source for that. Now every once in a while we get one where you actually can see the clot in transit and you can catch it going through that defect. Most of the time you can't, so it's inferred. Now there was kind of, the pendulum has swung a bit. There was a great enthusiasm initially for closing all of these. That's probably not right. Not closing any of them, that's not right either. It's somewhere in the middle. And clearly patients who have symptoms, patients who've had a stroke, especially in a young person, in which you do an exhaustive neurologic evaluation, you don't find any other cause, then those patients clearly do deserve consideration for a repair. Now, some can be treated medically, meaning blood thinner or antiplatelet agents like aspirin or Plavix. But in young women, for example, where bleeding is an issue or they want to have children and those medications are contraindicated and you shouldn't have them because they can cause bad things to the developing baby, again, those are reasons to repair the PFO.
That brings the question about aspirin and Plavix. But what were you going to say, Tammy? I'm sorry.
When you're talking about the surgical repair, one of the things that struck me so much when we did the videotaping of the ASD procedure is the cath lab, and that is just amazing science. That what all can you do by just a small slit in the thigh or groin area, and you can
list what you can do, Mike.
Well, again, the access through both the arterial and venous side with this new endovascular technology has allowed us to do many, many things. We can fix arteries, we can fix aneurysms, we can fix these defects in the heart. The neurointerventional people and neurosurgeons are going up into the brain doing things through this technique. So there are many things that can be done.
Aortic valves.
Aortic valves, transcatheter aortic valves are now being...
Are you doing them?
We are not doing them at this point. It's still, there are two major companies that are involved in this. All of the centers right now still are really research centers or investigative sites.
So that would be going up in the...
Up the artery and up to the aortic valve, and then they're putting in...
They put basically, instead of opening the chest and and surgically taking the old narrowed valve, this is for narrowed aortic valves, taking that valve out and replacing it with a new valve surgically. They're doing it with a technique where you go in with a balloon, dilate that area, and then you place this new valve, which is actually an expandable type, and you can actually, there's a balloon expandable and a self-expanding, they're two different styles, but they basically then tightly fit, and they fit by a pressure fit, and they're placed into the aortic valve. So it's not quite yet ready for prime time, but it will clearly come. There are some techniques now to repair mitral valves that are leaking in the same catheter type techniques. So this business of structural heart disease will change dramatically, certainly over the next 10 years.
I would go ahead.
Oh, you were going to mention
I was going to talk about aortic aneurysms. You can put a new lining through this balloon technique with just a little nick in the groin, and you don't have to open up the abdomen like we used to have to do.
Right. Well, and what you're talking about is what we call endovascular aortic repair. It's done with these a covered stent, the stent that has a covering on it that can be placed, and basically what it does is it provides a new sleeve inside the old one, and you get a seal at the top, a seal at the bottom, and then it depressurizes that sac, so it no longer will expand or no longer risk of rupture. Now, many patients, and with the new technologies, about 60 or 70% of patients can be effectively treated that way. Not everyone, and unfortunately, by the time they break or rupture, some people don't make it to the hospital. The few that do we've been able to actually treat a few with this technique, but some of them still require open surgical repair.
This may be a poor comparison, but is it kind of like running a new length of PVC pipe inside an old
exactly
metal pipe? Okay.
That's exactly right. You put basically a new pipe inside an old one.
It's not PVC, though. It's
That's
much more technical than that. You were going to bring up medications, I think.
Well, let's talk about aspirin preventively. Of course, there's a difference between Plavix and aspirin, but not much. And there's a huge difference between the cost. A lot of people talk about using aspirin as a preventative for vascular disease or to prevent strokes and heart attacks. I would add that there's a place for aspirin to prevent polyps of the colon, and that when you see a combination of polyps in the colon and some vascular issues, then you've got double reason to use aspirin. So anyway, I'm asking you about those drugs. How powerful are they? How effective are they? When is it appropriate to use it as a prophylactic or preventative measure?
Well, it's an area of evolution and change, and antiplatelet therapy, which is the aspirin, inhibits the first line of what causes a clot, the little platelets that, from a primary prevention standpoint, there's still some controversy now, and so
primary meaning no illness,
no prior
50 years
problems.
Of age is the only illness. Yeah.
There was the physician health study that suggested there may be some benefit, but the fact is that you really get your bang for your buck when you treat someone who has disease, what we call secondary prevention. You already have a problem. Now we're trying to prevent the problem from becoming worse, and so aspirin clearly has an important role both in the prevention of stroke and acute heart attacks. The exact dose, there's again controversy, but the minimum is probably 81 milligrams. Now, there have been lots of studies now looking at some people are more resistant, and some people, if you're a smoker or non-smoker, you may need more or less. Plavix really came on the market. Ticlid, which was the predecessor to that, really came on the market as a very powerful antiplatelet agent, as an alternative to aspirin. It is more powerful. But as you say, it's more expensive. There's some risk of bleeding. It really was a tremendous tool for those patients who are intolerant of aspirin. And there are a few patients who truly are allergic to aspirin. Not very many, but there are a few. Yeah. And so it provided an alternative. Like many things, we thought that, if a little was good, a lot was better. It turns out that if combining aspirin and Plavix, especially in the higher doses, does increase the risk of bleeding, is probably not the thing to do. So you should probably be on one or the other. Now, we use Plavix very commonly after heart stents or angioplasty, after peripheral stents, and with the new drug-eluting technology, these Plavix agents have really been very important because they help prevent that clot from forming around that stent. So they're still very important medications.
Do a two-sentence story of drug-eluting stent.
Yeah.
Well, the drug-eluting stents, there are two different types of chemicals, but basically what they do is you coat the stent with a chemical that prevents the cells from growing and a lot of scar tissue from forming in a very simplistic way. But so by doing that, we enhance the patency, meaning that the stents tend to stay open longer, and clearly it's been they've been very helpful. Especially in the coronary circulation, in the small blood vessels of the heart.
But the downside?
Well, the downside is that you are at increased risk. You have to be on the Plavix or other medications
for up to a year.
Up to a year, because of the fact that you're at greater risk for having a blood clot form. So, for example, if you fix someone's heart in anticipation that they're going to need an abdominal operation or a colon resection or some other bigger operation, then it may be better to treat them with a bare metal stent, not use the drug-eluting one, because you don't want them to be on those kind of powerful blood thinners when they have an operation for some other problem.
Okay, and now just to back up a little bit, the term antiplatelet means...
If you explain the types of causes of clotting that goes on, and let's just say that there's two major, it's a simplification, but two major ways. The first story is that platelets, which are these little tiny pieces of cell that have broken off from a major cell attack, where there's a first thing that starts to glue up on an area that's a sore or something that triggers it. The platelets are the first things that clot. The second kind of system starts from proton system that develop in the liver, and that's countered by Coumadin or warfarin, that type of a treatment. And so there's two whole systems, the platelets being more important for certain types of vascular disease, and the other clotting system that is countered by warfarin is more important for others. It's just two kinds of systems that work differently and seem to be important in different kinds of diseases. Now, you would add to that.
Well, the only thing I'm always reminded of the story about the little Dutch boy, when the break in the dike, okay?
Yeah.
Little Dutch boy comes and puts his finger and stops it, okay? That's the platelet. And then the rest of the townspeople come with the sandbags and build up the dike. So
Yeah.
in a very simplistic way, that's really what it is. The platelet is the first line of defense. And unfortunately, the platelets tend to accumulate anytime there's a little bit of irritation or injury of the blood vessel. So they often provide a matrix, or they lay down the first foundation for these plaque formation and then the narrowing to occur. And by preventing that, making them less sticky so they don't stick to that irregular or roughened area of the blood vessel, you can avoid that
clotting cascade.
That cascade, that's right.
Okay.
The avalanche.
Right.
Does this get back to the whole smoking aggravates things and then the platelets
Let's get back
show
to
up?
the smoking and
I'm sorry, I don't mean to.
Yeah. No. Go to smoking and aortic aneurysm.
Well, as we briefly touched on the fact that aneurysmal disease is also a degenerative process. It also is tied to atherosclerosis. So not all atherosclerosis or hardening of the arteries is related to blockage. Some of it can be this degeneration and widening or formation of an aneurysm. There is no question that tobacco use significantly contributes to that. And in fact, the current guidelines for your first Medicare evaluation, for example, really were limited to men 60 years of age or 65 or older who had smoked, because they're clearly at the higher risk. So smoking does contribute significantly to the development of these aneurysms because of it, the result in the destructive elements. Now, obviously there's some important chemicals, what we call metalloproteases, that help dissolve the structural elements of the blood vessel.
I like the phrase important chemicals
better. So it's a complex thing that none of us totally understand, but there's lots of research being done on that.
I want to highlight what you said. They have found that it's fair to do a screening ultrasound on men, not women, who are 60 to 70 years of age, who ever smoked, like smoked 100 cigarettes.
100 cigarettes in their lifetime.
In their lifetime.
Yeah.
So
that isn't very much in the
any amount of smoking puts you at risk for this major aortic aneurysm. It just triple, quadruple, it just hugely affects it. Who knows why? It just does. And so if you've been a smoker and you're a guy, you need to have that ultrasound done. Well, Medicare, in all its wisdom, says, we'll pay for one. And we'll pay for it only that the Medicare, welcome to Medicare physical, unless you present with pain, palpable mass, and whooshing sounds in your belly. So
that's important to know that
it will be paid for by Medicare at the Medicare Welcome to Medicare physical. And that's the only time they'll do a screening ultrasound, and they should do it on every male who ever smoked.
That's
anything to add?
That's exactly right. And many of the societies, the Society of Vascular Surgery, the Society of Vascular Medicine, all petitioned the government to try and get that changed, but were not successful. As a result, there's been a proliferation of a lot of screening, private screening programs, and many of them are actually very cost-effective.
We see the flyers in the paper.
Right, and so
that's the one part I think it's worthy.
If you have a family history of aneurysmal disease, if you've been a smoker, if you have blockage elsewhere and you already have had a heart attack, those are all good reasons to have that. Now, if you're identified with an aneurysm, then you can follow those, and Medicare will in fact pay for serial follow-up to see whether in fact it enlarges.
Or if the doctor finds a mass,
right.
if he hears it. Yeah. But we're running out of time, right?
Well, we've got a little bit longer here, and so when we're talking about abdominal aortic aneurysms, that's catastrophic business, right?
They die.
It certainly can be, and as they get bigger, they have a tendency to break or leak. And when that happens, it's a catastrophic event. So clearly you would like to fix them before that happens, and that's related to size. So the larger ones are at greater risk. Smaller ones can be watched very safely, and many of the smaller ones do not need to have anything done.
And the cutoff size is?
For most aneurysms, it's around 5 or 5.5 centimeters. If you're less than that, the small aneurysm study would suggest that you don't need to have anything done. However, as they get larger, that risk goes up, and so then you would like to intervene sooner rather than later.
One take-home sentence, quick. Take-home message.
About aneurysmal disease?
About anything.
Oh, well, I think the most important thing that we talked about really was the preventive aspects, and I think that is that smoking cessation is critical. If you're a smoker, you need to stop, and that there are tremendous benefits to exercise, both for a survival benefit as well as for a quality of life benefit.
Okay, Dr. Holm?
Exercise is way more important than any pill. Lipid-lowering agents don't even come close.
All right, doctors, thanks so much. Stay tuned for the Homespun Perspective and then What's New in Medical Science.
Looking for reliable healthcare information online? You can start with the resources link at the On-Call website. From there, you can access a variety of accurate and dependable information sources, including the South Dakota State Department of Health and Medline Plus.
Do you remember the short story, The Telltale Heart by Edgar Allan Poe? It ends with these words: "No, no, they heard, they suspected, they knew, they were making a mockery of my horror, and now again, hark, louder, louder, louder! Villains," I shrieked. "I admit the deed, tear up the planks. Here, here it is the beating of his hideous heart." I have a real story of a telltale heart. His wife almost had to force him to come to the emergency room. She said he was unusually irritable. Although he typically kidded with me, this evening the smile was gone. He complained of a throbbing abdominal discomfort that spread into a tearing pain into his back. On exam, he had a pulsatile abdominal mass. And upon listening with a stethoscope, I could hear a repeating and prominent whoosh, whoosh. My patient had the telltale indications of a dissecting abdominal aortic aneurysm. The aorta is the largest blood vessel that extends from the top of the heart, and it provides oxygenated blood to virtually every cell in the body. It's a multi-layered, high-pressure hose that arches upward and around, sending tributaries to the neck and brain, the arms, and down through the chest, past the diaphragm. Once it reaches the abdomen, the aorta sends branches to the bowels, kidneys, and finally splits to the two femoral arteries, providing blood for the legs. We measure the continuous pressure exerted within the aorta in millimeters of mercury, and it's pressures that vary between 120 down to 80 on average. But in a hypertensive person, this can be much higher. After many years of such pressure, and especially after years of smoking, the walls of this mighty vessel can weaken, and blood can split into one of the layers of the vessel, dissect down, and finally rupture or blow out the vessel, causing immediate death. Some 14,000 Americans die from this condition each year, and that would be less if proper screening occurred. My patient did not die, but he went to surgery, and within hours, a new lining to his aorta was provided. Now, something like 15 years later, he's still alive and joking with me. I saw him last week and listened to the beating of his glorious, not hideous, heart. We'll be right back.
And we're just about out of time for tonight. Remember, On Call is rebroadcast on SDPB Digital Channel 2, Mondays at 11 a.m. Central and Wednesdays at 4 p.m. Central. Once more, I'd like to thank our guest, Dr. Michael Bacharach, and our medical editor, Dr. Rick Holm. Thanks to our phone volunteers, and thanks to you for watching and calling in. Have a good evening.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
To learn more about life and health, you can order your copy of The Picture of Health, a beautiful book containing insightful essays and evocative images by on-call medical editor Dr. Rick Holm and Dr. Judith Peterson. This book, containing healthcare advice, stories of medical history, and meditations on healing, can now be yours for $17 at the South Dakota Ag Heritage Museum. Call 1-877-227-0015 to order. This offer is made by Ag Bio Communications at South Dakota State University.